Purple Solutions to Fix Healthcare in America podcast. Each week, we explore bipartisan solutions to healthcare reform through discussions with leading experts from across the country. To learn more, go to purplesolutions.org and join us at our Healthcare Economics Summit on July 31st.
Hello, everybody. I'm Dan Sem, Dean of the Batterman School of Business and Director of the RX Think Tank at Concordia University. And I'm here today with Dr. Robert Graboyes. Dr. Graboyes is a Senior Research Fellow and Healthcare Scholar at the Mercatus Center at George Mason University. And he's also author of Fortress and Frontier in American Healthcare. Maybe he'll tell us a little bit about that later. Previously, he served as Healthcare Advisor for the National Federation of Independent Business, Economics Professor at the University of Richmond, and Regional Economist and Director of Education at the Federal Reserve Bank of Richmond. And most importantly, he's speaking at our July 31st Healthcare Economics Summit. I don't know, Bob, did I miss anything important there? I'm sure there's a lot more to you.
Well, I don't know. My first big job in economics was Chase Manhattan Bank. I was their economist for Sub-Saharan Africa. So I have sort of wandered all over the landscape of economics.
Okay. I never knew about that part of your adventure. And you're an accomplished musician too.
Yeah.
So, okay. Well, Bob, thanks a lot for speaking with me and us today and on July 31st. So last fall, it was great. We had you speaking at our last healthcare summit. And also when you spoke then and in the chapter that you wrote for our Purple Solutions book, you talked about the need to focus on the supply side rather than the demand side in healthcare. So I don't know, maybe people need a little bit of an economics refresher, but can you talk about what you meant by that and why does it matter? Why should we be wanting to focus on the supply side?
Sure. So for at least 75 years, we've been debating healthcare in this country. And we've typically argued over federal insurance policy. So do we give this person a policy? Do we give that person? How much do we charge, et cetera? What are the co-pays? All of these issues. But the key is the amount of health care that is provided to Americans is determined by the number of doctors you have, the number of nurses, the number of hospital beds, the number of laboratories, the pieces of equipment, the drug formulary, and the recipes that we have, the algorithms for combining all of these things into care. Now, in 2009, we had a certain quantity of all of those resources. We had certain recipes for combining them. And then in 2010, Congress passed and President Obama signed what became known as Obamacare, the Affordable Care Act. And it didn't change substantially the number of doctors, nurses, hospital beds, lab equipments, the formula, nothing much changed. So therefore, there were people who are now, because of the ACA, they're getting more care than they did before. But if all those resources were busily being used before, that means somewhere out there, someone's getting less. And if someone is paying less, someone else is paying more. So what we really did in 2010 was we sort of moved the chairs around on the deck. Now, in fairness, bipartisan purple fairness, when the Republicans offered a string of bills after President Trump took over, I made the same argument about everything they were proposing. And when Senator Sanders or others propose single payer, it's still the same thing going on. You're not increasing the quantity of resources available, nor are you substantially changing the recipes for combining them. So I really want to focus on, most of my work focuses on how do we change the supply. So we're not just arguing over who's writing checks. So how do you get more bang for the buck out of healthcare? And essentially, there are three ways you do it. You can transfer, and this is a simple way of looking. It's more complex, but to put it really simply, you can take work that highly paid doctors are doing and shift it downward to nurses, nurse practitioners, other advanced practice nurses, in some cases to technicians. In some cases, you can transfer some of the work that doctors do and you can automate it. You can do everything by sort of automating the doctor's processes to creating artificially intelligent machines that do part of the doctor's job, things that doctors have always done. I will always give my example, and I have two of these machines. This is a device that does an electrocardiogram. I had one episode about 4 years ago of atrial fibrillation, arrhythmia, and this thing allows me anytime to monitor my heart, see how it's doing. And now
It's based on touching those electrodes, or you need to hook something up to you, or?
Yeah, no, you just click the app, do this, watch 30 seconds tick off, and at the end, I'll do it while we talk, while we look at other things. But I've also got it on my Apple Watch. That'll do the same thing now.
Right.
And so that has taken what used to require a doctor to administer an electrocardiogram, and now I can do it myself. So transferring work from doctors to other skilled medical personnel to intelligent machines, and with the aid of those first two, to people like me, to patients. So those are three ways you do it. And then you can actually expand the amount of care that is being provided with a given quantity of resources, a given quantity of expenditures. Now, the great thing, and we'll have plenty of chance to talk about this, in the last 3 months, as the pandemic has raged across the country, essentially the states and the federal government have been doing, most everything I talk about in this. And they didn't get it from me, I'm sure, but they're doing what I've sort of been yammering about in my papers and my writings for years. We can talk about, I won't rattle it off now. I'll let you ask another question. We'll get back to what they've done. This also includes things like changing the rules, the procedures for the FDA. And just so I'm now.
So how's your heart going?
It's just starting. Let's see. It's going to depend. Yeah, there it is. So I'm at 69, 70 beats a minute, 22 seconds. I'll just let you know when it's done. So now we can continue our conversation.
If there's a problem, I'll have to figure out how to resolve it from a couple 100 miles away.
Well, I can tell you, I know enough about how to read it now to know that it's perfectly fine, which is an interesting thing. And when I first had this episode, I was kind of scared. There you go. So there you can see.
Looks like you're okay.
Pattern. I'm okay. No.
Oh, there's an EKG. Rhythm. Very cool.
There's an EKG, and it says no abnormalities.
Yeah.
This device, for instance, at least 2 occasions kept me from going to an emergency room when I was worried that I had a problem. It kept me out. Now, that meant I like to say that I probably saved the American healthcare system $10,000 by buying this $99 device.
Yeah.
But what it also did was there were a whole bunch of doctors and nurses and beds, whatever, that were available for someone who actually needed it, rather than for me, who it turns out didn't need it. So this is a way that you expand the supply side. Same number of doctors out there, but now they can provide more care because they're not dealing with people like me coming in with a non-problem. Mm-hmm. And we're in an era where just the technologies are exploding on these.
Yeah.
5 years from now, I think it'll be unimaginable where we are.
Yeah, and you paint a really vivid picture of that in your chapter and in your other writings. Mm-hmm. I guess, I'm excited about this kind of technology and consumerizing care and giving us access to that kind of technology. I want to touch on sort of what are the barriers to us getting there, and I guess my hypothesis is that the barriers could be either government/regulations or an entrenched industry. And so I guess we'll take that stepwise. So the first one, and you wrote a great piece called Fortress and Frontier, and you talk about how a fortress mentality in healthcare is getting in the way of innovation. Can you talk about what is that fortress? Is it some people cynically call it the industrial medical complex? Do they have an interest in not letting these innovations happen, or talk about what you wrote in Fortress and Frontier? So
yeah, it's a combination. It's a sort of a bad version of doing well by doing good. You can honestly feel you're helping patients and at the same time find, well, I'm making a whole lot more money by keeping competitors out. So in my book, I described it. The fortress is an idea that the job of the government in healthcare is to do two things. First is to imagine every terrible thing that could ever possibly happen to a patient and throw enormous resources at trying to stave off those things beforehand. So risk aversion in the extreme. And the second thing is to protect insiders. That could be doctors, hospitals, insurers, pharmaceutical companies, can be all sorts of people in institutions. But it's a mentality of, well, doctors have worked very, very hard to get where they are. They had to go to med school, they had to do residencies, and need to keep their incomes up. And this hospital's been here a long time, and it's done great things for our city. We don't want to let a competitor come in and close it down just because they're more efficient or serve the patients better. So it's a sort of a protectionism. And yes, it comes from laws, comes from regulations, and it does, as you suggest, come from private institutions, medical societies, other industry groups. And sometimes I think if you strap a lie detector to them and say, are you doing good for the patients? They'll say, absolutely, we are, and they'll pass with flying colors because they can think, it's actually good for my bottom line and it's good for the patients, so let's keep the competitors out. Sure. Let's make sure that a new hospital doesn't move into town. Let's make sure nurse practitioners can't do what doctors have traditionally done. Let's, there's a long string of these. Let's have licensure regulations that prevent the doctors from moving into this state and competing with the ones who are here. Let's make sure telemedicine doesn't cross state lines. So lots of ways it works.
That includes how we handle electronic medical records, right? I mean, if you make it hard to move from provider to provider, that's sort of anti-competitive, but the argument is, oh, well, we're there to sort of help the patient and only we can make sense out of this information for you.
Yeah, and I suspect they may sincerely believe it.
Yeah.
I have done some writing on what electronic health records ought to look like in the future, and my co-author and I, who's a doctor, we, for the purposes of our writings, renamed them digital health biographies for several reasons. One, we think they should be more all-encompassing, not just your doctor's visit, but also what goes into my my wearable and this thing, and maybe my own documentation to say, my grandfather died of a stroke in 1936. Maybe that should be in my records.
Yeah.
And so we called it that, but also one reason we decided to call them digital health biographies instead of electronic health records is, by and large, doctors absolutely despise electronic health records, electronic medical records, they sometimes called. And I think it's because they have been designed badly. They have not been designed for the purpose of the patient, for the benefit of the patient, or the benefit of the provider. It's been designed for the benefit of the government and for insurers. And it really, therapeutically, clinically, they're not particularly valuable. So we need to get to a future where electronic health records actually are valuable, useful, and where patients and doctors actually want to use them because they serve a good purpose.
Right. Yeah. Okay, so that is a bit about the fortress. And frontier. I guess the frontier is the innovation and the disruptions that are positive and good.
Frontier is more like the information technology industry, where no one promised IBM that they were going to keep Bill Gates and Steve Jobs from competing with them. So, well, he doesn't, they don't have the credentials we do. We shouldn't let them build computers. That would be wrong, could do damage. And so we allowed heavy-duty competition, and we allowed people to take significant risks. It was an interesting public policy decision, and I'll have to say I'm fascinated by it, but I don't know the history of it as well as I'd like to. I think it's one of the most interesting political science questions of the last half century. How did Congress and a couple of presidents get great sense and do something really smart at the beginning of the 90s by opening up the internet and allowing competition and allowing risk-taking. Now, I'll often get at this point, well, you can't talk about computers the way you do a doctor, you know, that's just a cell phone, that's not your heart, your lungs, and whatever. And I will argue that these devices, the ones we're talking on, the one I'm holding here, have the potential to do greater damage to you as a person, probably than just about at least as dangerous as anything a doctor is going to do. In the last 30 years, most vividly, the attacks of 9/11 could not have happened without the cellular phone system and other computer innovations that allowed a ragtag group to coordinate attacks. You know, just these were amateurs, but they were managed to launch some of the most terrifying attacks out there. And other things, IEDs in the Iraq War, improvised explosive devices that killed and maimed thousands. Couldn't do it without cell phones. Identity theft. There are new types of fraud that occur every day with using computers.
Right.
Lives have been ruined. Also, they're dangerous devices, but somehow public policy makers in the early 90s said, we know they're dangerous, we know there are going to be risks, let's let it proceed, and when a problem occurs, we'll deal with it then. We're not going to try to anticipate every risk that's out there and stop it beforehand.
Yeah.
So, and
that's always a concern with technology. Is it could be for good and for bad. You can't hold technology back because of that. But you know, one thing that intrigues me in terms of the fortress and frontier confrontation is, you know, with telehealth becoming so prominent now with COVID. That'll be my next question: is how does COVID impact things? But I've encountered this term that I only learned about, you know, for telehealth called price parity. So there's a concern that now you can get your telehealth, you know, remotely like this for maybe $20-50, whereas if you did it in the hospital, it'd be a couple $100. And some of the hospitals are arguing that, well, we want to be able to charge you the same price, $200. That kind of strikes me as a little anti-competitive. There's a solution out there for the consumer, and you know, I don't think we want to be told that we can't pay the market price for that because the big provider doesn't want us to. That's the fortress.
So at Mercatus, we have something called HOPE, the Healthcare Openness and Access Project, that looks at the 50 states and the District of Columbia and asks which state is open to telemedicine, which is open to broader ideas of licensure and scope of practice. And one of the things we included on there, and we wrote in there that we had some heartburn about how to put it in, was some states began using paying for telemedicine at parity. So they were going to pay the same price for telemedicine visit that they would an in-person visit. And we graded that as a good thing because they were allowing payment for telemedicine. That's good. On the other hand, we mentioned we're not completely happy with it because the parity means that you are eliminating one of the great arguments for telemedicine, which is cost cutting. If a telemedicine doctor can spread out broadly and serve peak demand over this state and then this state and over here and over there, you're cutting costs. And if they can do it for less money, well, that's a good thing. But as you said, some on the inside say, no, you shouldn't be able to charge less, which essentially is a cartelization of that market. It is an anti-competitive behavior. In other fields, it would probably be considered an antitrust violation.
Yeah.
So yeah, parity is a problem. It's great that they're paying for telemedicine. It's a problem if you say you can't enjoy the cost benefits of telemedicine.
Yeah. Well, now we're talking a lot about telemedicine, and I think with COVID, people are really getting more comfortable with it than they were a year ago. That adoption curve, I think we were looking at a few years, maybe now it's happening, but more broadly, what do you think? So there's a lot of huge number of negatives that have come out of COVID, but what positives have come out of COVID pushing us out of our comfort zone in healthcare for positive changes?
Well, all of a sudden, all the ideas that, again, that I've been talking about for years, we need more telemedicine, broader scope of practice for non-physicians or for physicians even. Um, you know, more lax licensure, allow doctors from other states to practice across state lines.
Yeah.
Allow allow a broader sense of licensure for for other professions as well.
So those are a lot of sort of regulatory loosenings.
Right. Quicker approval processes for drugs at the FDA. Well, all of a sudden, COVID happened, and there was more innovation in the last 3 months than I've seen in my 40 years as an economist.
Yeah.
So all of a sudden, all these ideas which had been resisted, we kind of like the way we've been doing it for years, and let's not go and change anything. All of a sudden, it became obvious that those set ways, especially during an emergency, are dangerous, even deadly.
Yeah.
But I would argue that that's always been true. It's just been less obviously true in more normal times when we weren't facing this catastrophe. So it has absolutely, I've been giving telemedicine talks for years. I've used telemedicine. There's a story, I probably told it when I was with you, that my mother's life was almost certainly saved by sort of unofficial telemedicine. She was talking to my nephew, who was a doctor, and in the course of the conversation, he recognized that she was in toxic shock in the early stages, and in septic shock. And they rushed her to the hospital and saved her life. If she had waited a day or two, as she planned to call a doctor, she almost certainly would have been dead. So, but still, a lot of doctors were traditionally very uncomfortable with the idea of seeing a patient as I'm seeing you now through a computer screen. Oh, well, how can I do that? Well, they've been forced to do it. And now a lot of them are realizing this actually works very well. Yeah. Not only that, there are even instances where it works better. So I've talked to people in the field of telepsychiatry.
Yeah.
And one of the tough things is you've got a psychiatric or psychological patient coming into the office with an appointment 2 p.m. next Thursday. And by that time, the patient has convinced themselves, I don't really want to talk about my problem. I'm going to be quiet. Whereas there seems to be a very different dynamic when the calls can be more spontaneous, when they can go through the computer screen, when they're in the comfort of their home rather than in an intimidating doctor's office.
Yeah.
And they can type in reports and shoot them off in the middle of the night when they're at a moment saying, I need to get better. I want the doctor to know this. Whereas if they had to do it by light of day, they might close up and say, I'm not going to talk about that.
Yeah.
So there are instances where it works better. And I think doctors, my sense is they're very quickly learning this is a really powerful way to practice medicine. People don't have to delay if they want to call a doctor at 2 a.m. for a problem. You can save a lot of pain and misery and even stop deaths unnecessarily if the patient calls at 2 a.m. and says, I think I'm sick and what should I do, rather than I'll call the doc in a couple of days and deal with it.
Yeah. No, I can see the big benefits, and that's even sort of separate from the whole fortress concept. It's just a patient and a doctor being willing to try something new, to adopt a new approach. And now that they've been forced to do it, maybe they're going to see where it was more beneficial.
Yes.
Yeah. We talked a little bit earlier about the kind of the barriers to these kinds of innovations. So I guess we touched on that already. I guess maybe if I can, and you might need to explain this to people that don't know what you mean by this, maybe, I don't know if I'm pronouncing this correctly, the Narayana riddle. Yes. Narayana riddle. So I think that's getting at some of the problems and lack of efficiency in healthcare delivery. But can you explain what you mean by that? The riddle.
Sure. I'm writing a paper now that involves a very interesting, one of the most interesting healthcare providers in the world today is a company called Narayana Health. It's in India. They have about 20 hospitals in India and one in the Caribbean, just a bit south of Florida. Mariana does all sorts of procedures. They're led by a visionary by the name of Debbie Shetty, who was Mother Teresa's physician. So talking to someone at Concordia, that's a good point to bring up.
Yeah.
But she apparently implored him at some point to try to figure ways to bring quality health care to the poor of India. And he devoted his life to that as keeping his promise to Mother Teresa. So, and I'll just give perhaps the most famous aspect of it. So if you were to get a heart bypass operation in Virginia here or Wisconsin there, it would set you back set somebody back about $100,000.
Right.
At Mariana, the cost is between $1,000 and $2,000. I think it's closer to $1,000. So just between 1% and 2% of the cost. And their outcomes are among the best in the world. And I've talked to doctors who visited their hospitals, and they can't believe the quality and the dynamism and just the whole structure of the place. It essentially operates according to the same methods that a Toyota factory does.
Is that the riddle? How can they do it for 2,000 and we do it for 100?
Right. So Debbie Shetty wanted to bring this to America, and he teamed up with, and I know we're both, you and I are both familiar with them, the Ascension healthcare system, the largest Catholic healthcare system in America. Yeah. And Mariana and Ascension partnered together to build a hospital to serve basically American clientele. But for whatever reasons, and this is the subject of our research, they decided it couldn't be done in the United States, that there are just too many obstacles here. Mm-hmm. So they built a hospital in the Cayman Islands, an hour and a half south by plane from Miami. And Shetty at the time said, rather famously, best place on earth to build a hospital is on a ship moored just outside of the territorial limits of the United States. You sail it into those limits, into U.S. territory, you're no longer able to do any of this. And he said the Cayman Islands was the closest they could come to a ship on a hospital on a ship just offshore. So the two questions, the two riddles are, how can they provide bypass operations for $1,000 to $2,000? And people instinctively say, well, probably costs are less in India. Some of the costs are less. Doctor is paid less there than here, but other things like capital costs are actually more. So it's not clear that that's it. So how do they do what they do? And secondly, why can't you do it here? Why can't a very large American hospital chain team up with this guy and say, let's bring the same sort of standardization of division of labor, all the things that go into making Mariana what it is, and do it here. And by the way, the Cayman Islands, they don't do it for 1,000 or 2,000 either. I think last I looked, it was about 30,000 to do a bypass. They don't get the same volumes down there, so different cost bases and different patient base. But the fact is that's still a 70% cut from the U.S. cost. So the two riddles are, how do they do what they do, and why can't we do it?
So I don't know if you're going to give us any hints, but the big difference is the level of regulations present within the U.S. versus outside the U.S. Is that sort of at the heart of the riddle somewhere?
I think that's part of the riddle. We also have laws that make it, and one of Mariana's hallmarks is they vertically integrate quite a bit of their operation.
Oh, okay.
So they cut costs by cutting thousands of costs by little bits and pieces. So one of the things that Shetty noted in some interview was, he said, we were buying, the hospital gowns that patients wear, those flimsy looking things that don't ever fasten right in the back. Mm-hmm. So we were buying them from a supplier in England. And we said, we're in India, we make clothes here.
Yeah.
Can we do them less expensively here? And so they he said, you'd be surprised how much a hospital can save by trimming down the costs of hospital gowns.
Right.
They have certain, in some cases, they build factories around their hospitals to supply resources to the hospital. I'm not certain, again, this is something for the research. I'm not sure it can be done here because I think you'd run aground of antitrust laws and a variety of other, we have laws that are supposed to prevent abuse, bribery, that sort of thing, but they stop a lot of very good, sensible, prudent behavior from occurring as well.
Yeah.
So there are lots of reasons, and part of it is simply the culture. A good friend of mine said he ran a hospital system, and I said, how come they can do the sort of total quality management sort of business structure there, but no one can do it here? And he said, I did it here when I was running these hospitals. And I said, well, let me rephrase it then. How come you're the only American who's capable of doing this? And he said, because I did not come up through the healthcare system.
Oh.
He said, I was an
Fortress.
IT, yeah. He came out of the IT industry and just sort of accidentally ended up running hospitals.
Yeah.
He said, I didn't know all the things you can't do, so I did them. And he said, I also was not going to tolerate the culture that prevents it. So
Yeah.
he said, one of the big problems is American medical culture is very siloed.
Yeah.
This department and this department, they don't know what each other are doing.
Very fragmented.
At Narayana and to some extent at the hospitals he ran, there was a leveling of the organization chart so that people knew what was going on.
Well, pretty good success here in the U.S. that maybe helps get at the riddle is the Oklahoma Surgery Center, where they have bundled prices, so it's not fragmented. And I think they try to avoid working with insurance because the whole reimbursement model confuses things. And they have fixed prices for everything, and they're pretty reasonable and good outcomes.
Sure. Yeah, sure. Go on their website, anyone, Surgery Center of Oklahoma. You can find, last I looked, I think it was 850 different surgical procedures on outpatient procedures. A lot of orthopedics, that sort of thing, but lots of different things. And you go on their site, and it's really great graphics. You'll see a human body. You go, I've got a shoulder problem, blunk, and up come a whole bunch of different listings. And to the penny, it tells you what it will cost in advance.
Yeah. And I heard that if it doesn't go well and it needs to be repeated, there's no charge for that because that was their problem, that they didn't do it well.
Well, I know Narayana does that.
Yeah.
And I ought to know, since I'm good friends with Keith Smith, who runs the Surgery Center of Oklahoma, but I'm not sure what his money back guarantee is.
Well, I'm hoping Keith can speak at our event. He was happy to hear that you were speaking.
Keith's the best. He's a fascinating character.
Yeah. Okay, so my very last question is we have an election coming up. How can we get politicians to understand what is needed? Maybe what is needed is to get out of the way or to change regulations. I don't really know, but do you have any words of wisdom for Joe or Donald or voters coming into November? So.
Well, in this year, the answer to that's gotten a lot simpler. It's look around. They seem to have, a lot of them seem to have discovered it in very big ways. All of a sudden, again, states have just been saying, you know what? No, forget about certificate of need. You don't have to ask us for permission to build a hospital or add some beds or buy a CAT scan machine. Licensure, I don't care. Doctor's license 3 states over. Wants to do some good here, we're not going to argue with it. Nurse practitioner wants to practice autonomously where there's no doctor, not going to argue with the nurse practitioner. FDA, well, usually we would take 15 years to think about this, but how about if we just decide on it? So I think they've discovered a lot. The key is, and I think this probably is the key for it, say, look at all the good that has come out of this. COVID is horrible. Coronavirus is certainly the worst thing that's hit the country, at least since Pearl Harbor, if not before. But look at all the good that's been done by shedding these old ways of doing business, and understand that holds true even in normal times.
Yeah.
This is not just something for emergency. Emergencies rang the alarm and you woke up. Now stay up and do something about it.
Okay. So look at the positive changes we've done during COVID and try to learn from them and maybe implement them longer term. I hope some of those changes are going to last after COVID.
I hope so.
Yeah. All right. Well, thanks, Bob. I really appreciate you taking the time to talk.
Always.
All right.